So here's a nice graphic that shows if you build it, they will come. I'm pleased to be able to say that our office has been growing steadily since it was launched. We probably manage right now about 150 grants just in our office alone. But when we do our portfolio analysis, and I didn't drop slides in here, you can go to our website and look at some of those. We usually do it NIH-wide because we know there are other institutes that fund this research, in particular the Nursing Institute. Aging is becoming interested in this. Mental health and heart, lung, and blood we've been trying to entice into this arena also, since we are often concerned about cardiac outcomes for some of our treated patients. So what is the research that we're funding telling us? I don't think it's going to be new news to anybody who works with patients in this audience. The good news overall is that when we evaluate survivors, and we ask them to fill out our forms and questionnaires and tell us how they're doing. These are patient-reported outcomes. And most of the science is really driven on patient reports, so without our asking them, we wouldn't have this information. Most of them tell you there was some, even though there's some problems I have in here, I'm doing okay. The enormous resilience of our survivors is, for me at least, impresses me every time I encountered it. It is an inspiring response. But what we also know, and what they also tell us, is that when you're told you're disease-free, does not necessarily mean you are actually free of your disease. That cancer indeed affects virtually all aspects of an individual's life in one form or another. Some of these may be physical effects, some of these are psychological or emotional, some are social consequences, some may be existential or spiritual. We know that some of these are acute, so nausea, vomiting, anemia, hair loss will stop once the treatment stops. We worry a little less about those. Some of them, however, can be chronic or persistent, enduring after treatment ends. Fatigue, chemo brain, memory problems, lymphedema, sexual dysfunction, pain syndromes, and some worrying maybe late effects appearing months or years after treatment, cardiovascular problems, osteoporosis, and of course second malignancies among those that we worry about. We know that some individuals have many problems and consequences related to their illness, some have very few. Individuals of all ages are affected, and we are not very good prognosticators about who is going to develop what. We really lack the database to predict who is going to be most vulnerable to some of these toxicities. So it's hard, in many cases, to provide guidance to what should you be looking for. We can give some relative risks, but the individual identification of those is very challenging for clinicians moving forward. We know that, of course, the second malignancies or recurrence is what we worry most about. Our patients certainly tell us they're most worried about. We took a look at prevalence of second malignancies in our survivor population. As you see here, between 1971 and 2001, over 750,000 of those individuals actually had 2 or more cancers. As I said earlier, as we have an aging population, we're going to see more of this. They're going to be living long enough to develop second, third, and fourth malignancies. That's going to be an interesting challenge. Then how do you retreat somebody? How do you screen and perhaps prevent them from developing these if they're at all possible? We know some of these are iatrogenic, secondary to treatment exposures. Some will be genetically linked as we learn more about these. Some of these are environmental exposures, lifestyle associated. Some of them will simply be sporadic and a function of aging. So again, teasing out some of those and trying to figure out who might be at risk for one or the other is going to be very important. In the current SEER database, about 16% of new cases are in individuals who have a cancer history. So this is a significant burden in our cancer population. But that's not the only thing we need to be worried about. It's not just second malignancies and recurrences. We are worried about cardiovascular disease, obesity, diabetes, osteoporosis, I said, functional decline, and poor quality of life. When we looked at data from the National Health Interview Survey, this is, as many of you know, a major source of information about the health behaviors and health well-being of the population of the United States. This is the civilian population, non-institutionalized. So these are individual interviews that are conducted on an annual basis, and we pool these over 4 years. We can compare individuals who report a history of cancer versus no history of cancer. And while psychological problems and activities of daily living or instrumental activities of daily living, can you shop, can you work, can you drive your car, or can you bathe, etc., look pretty similar for those with and without a cancer history. When it comes to functional impairment, our survivors are telling us they are much more impaired than individuals who don't carry this history, and it certainly has an impact on work capacity. And of course, that's worrisome in our country when so many of us get our health insurance through our work situation. So trying to understand what that ramifications of that are is very important for us.